Another case. Case number 8. A 29-year-old lady, her age is 29, presents with a history of scanty menstruation. Okay, for 3 years. Scanty menstruation for 3 years. Further questioning revealed that her menarche was at 14 years of age. Okay, her age is 29. She is 29 now. She attained menarche at 14 years, fine, and menstrual cycles were regular for 5 years. Menarche at 14, cycles were regular for 5 years after menarche. Means from 14 years. Menses begin at 14 and from 14 till 19 years, for 5 years. 14 to 19, cycles were regular, but had become progressively infrequent. But now infrequent. Frequent means early, infrequent means delayed. For the past 3 years, she had no spontaneous menstruation. For the past 3 years, she had no spontaneous menstruation and only withdrawal bleeding after administration of hormones. For the past 3 years, she had no spontaneous menstruation and only withdrawal bleeding after administration of hormones. Evaluation at a local hospital revealed grossly elevated serum follicle stimulating hormone. Oh my God. Markedly elevated follicle stimulating hormone. Her anti-Mullerian hormone. So FSH is high, and what about AMH? AMH is very low, 0.2. It should be at least 2 nanogram per ml. It is only 0.2. Best method for ovarian activity assessment is anti-Mullerian hormone. Best method for ovarian activity assessment is anti-Mullerian hormone because it can be performed on any day, while serum FSH estimation can be done only on day 3. Her anti-Mullerian hormone levels are 0.2, low, very low. So ovarian activity is almost gone. Ultrasonogram shows 2 to 3 ovarian follicles. Ultrasonogram shows 2 to 3 ovarian follicles on either side, measuring in the range of approx 2 to 4 mm. My God, only 2 to 3 follicles on either side, and range is only 2 to 4 mm. You remember how to assess ovarian activity? Best is anti-Mullerian hormone. Other test serum FSH on day 3, and we count the number of follicles in ovary, pre-antral follicles. They should be at least 6. We have written in our note. Here they are only 2 to 3. She was referred to our clinic for further management. She is desperate to conceive. What would be the best management for her? So what is the last line of the question? What would be best management option for her? What would be best management option for her? She is desperate to conceive. Last line is what would be best management option. Means examiner is concerned with management. Desperate to conceive, उसको बच्चा चाहिए. ओवरी तो गई, अब बच्चा कहाँ से देंगे? Ovarian activity is gone. Anti-Mullerian hormone, the best indicator. Levels should be at least 2 nanogram. They are just 0.2. And look here, markedly elevated, grossly elevated serum follicle stimulating hormone and low serum estradiol level. So they are again indicating there is cessation of ovarian activity. It is indicating ovarian failure because estrogen is secreted from ovary. If there is ovarian failure, estrogen levels will fall like anything. And estrogen levels, if they are falling like anything, what will happen to FSH? Lower estrogen will give positive feedback to FSH. Basic physiology. And she is just 29 years, beta, and ovaries have failed. This is called premature ovarian failure, and she is desperate to conceive. Her ovaries are of no use. What is the best management option for her? Ovulation induction followed by serial USG monitoring. It is of no use because it is a case of ovarian failure. Her estradiol levels are very low. FSH is very high. Best indicator of ovarian reserve, that is anti-Mullerian hormone, is markedly low. Ultrasound, which is also done to assess ovarian activity to count the number of follicles, which should be at least 6, that is also indicating the same. So ovulation induction would be of no use. Ovary has failed. Intrauterine insemination. So in intrauterine insemination, we inseminate semen in uterine cavity. Then these sperms reach ampulla of fallopian tube and oocyte enters fallopian tube after ovulation. But her ovaries have failed. So even if you do intrauterine insemination, means you are inseminating semen in uterine cavity, then these sperms will reach ampulla of fallopian tube. Ovaries have to act, no beta. Then only ovulation will occur and then oocyte will be picked up by fimbria of fallopian tube and then fertilization will occur. So intrauterine insemination is also gone. In vitro fertilization with her oocytes. Her oocytes, her ovaries have failed. So how can you use her oocytes? If her oocytes were available, we could easily do intrauterine insemination if some other problem was there. In vitro fertilization with donor oocyte. So what is the answer here? Answer here is in vitro fertilization with donor oocyte. This is the answer available for this question because her ovaries have failed and she is desperate to conceive. So IVF with donor oocytes. Now you tell me, IVF with her own oocytes can be done in tubal block. If there is some MCQ like this where examiner is cooking the story for tubal block, most common cause for tubal block is PID. Another cause is endometriosis. So examiner might cook some story, lower abdominal pain, then she had multiple partners, something like that, because most common cause of PID is intercourse with multiple partners. So examiner will frame a MCQ like this: she is having a husband with multiple partners, or she herself is having multiple partners, then lower abdominal pain, then pus, fever, something like that. Then she got married, then for last 7 years she is not able to conceive. All that is going in favor of PID. Fine beta. So, and then if tubes might be blocked and if she was desperate to conceive, then IVF could be done with her own oocytes. Because this story where multiple partners or lower abdominal pain or fever or tubal block, ovaries are not affected. In this MCQ, in this story, ovaries are gone. Because ovaries are gone, her oocytes are of no use. So IVF with donor oocyte. In any problem where ovaries are not affected, IVF can be done with her own oocyte, like in tubal block. And do you remember beta? If she is having Mullerian agenesis, if this lady is having Mullerian agenesis, Rokitansky-Kuster-Meyer-Hauser syndrome, where uterus is absent, cervix is absent, fallopian tube is absent, upper part of vagina is absent, and if that lady is desperate to conceive, what would be best management for her? IVF with her own oocytes. Ovaries are normal in Mullerian agenesis because ovaries develop from genital ridge. So IVF with her own oocytes can be done in management of Mullerian agenesis. And instead of Mullerian agenesis, which word can be used by examiner to signify the same? Rokitansky-Kuster-Meyer-Hauser syndrome. RKMS syndrome is Mullerian agenesis plus renal anomaly plus spinal anomaly. So RKMS Mullerian agenesis, IVF with her own oocyte. Tubal block, IVF with her own oocyte. Examiner will not ask you a simple chocolate question. A female with tubal block due to PID is desperate to conceive. What is the best management option for her? IVF with her own oocyte. Days are gone, beta, for those questions. Days are gone. Tomorrow only in the evening, I will be posting all the recall questions of INI CET tomorrow, just so that you can have a look what is going to be asked in tomorrow's examination, which is INI CET, AIMS, PGI, JIPMER, NIMHANS. I am eagerly waiting to see those questions tomorrow and will post as soon as I get the questions. From many old mystians are appearing in tomorrow's exam, and we are trying our level best to help them out, and let us see what happens, how they are able to perform tomorrow. I have gone sleepless nights to help many of them, 2017 students, 2018 students. They all are appearing in tomorrow's exam. Let us see what happens tomorrow. So IVF with donor oocytes will be done here because ovaries are